keep going. I want to understand. I didn't understand MASLD.
No worries. Let's clear up MASLD. Metabolic Dysfunction Associated Steatotic Liver Disease. MASLD. Formerly called non-alcoholic fatty liver disease, NAAV, is when fat builds up in the liver due to metabolic issues like obesity, type 2 diabetes, or high triglycerides, not alcohol. It starts with steatosis, fatty liver, can progress to inflammation, steatosis, fatty liver, and unchecked leads to fibrosis or cirrhosis, where scar tissue impairs liver function. It's driven by insulin resistance, poor diet, or sedentary lifestyle, and affects about 25% of adults globally. Managing it involves weight loss, exercise, and controlling blood sugar or lipids. Want details on its progression to cirrhosis or specific treatments?
Well, it's okay. It's just a bit of a weird name, and it's hard for me to capture what it is, really.
Yeah, MASLD is a mouthful, and the name's a bit clunky. Simply put, it's when your liver gets fatty because of metabolic problems, like being overweight, having diabetes, or high cholesterol, not from drinking. Think of it as your liver storing too much fat, which can inflame and scar it over time, potentially leading to serious issues like cirrhosis. It's super common and tied to lifestyle. Want to know more about spotting it early or ways to reverse it?
I wanted you to tell me about dye injected through a catheter into the pancreatic or biliary ducts. When did this happen?
Dye injection through a catheter into the pancreatic ducts happens during a procedure called endoscopic retrograde colon-pancreatic adductory, ERCP. It's done to diagnose or treat issues in the pancreatic or bile ducts, like blockages, stones, tumors, or strictures. A doctor threads an endoscope through the mouth to the duodenum, locates the duct's opening, and slides a thin catheter through the endoscope into the pancreatic or bile ducts. Contrast dye is then injected, and x-rays are taken to visualize the ducts for abnormalities. It's typically used when symptoms like jaundice, abnormal pain, or abnormal liver tests suggest duct problems, often related to conditions like gallstones, pancreatitis, or chronic liver disease. Risks include pancreatitis or infection, so it's not routine. Want more on why it's ordered or potential complications?
So what is this? Why do we do it? And what is ERCP?
ERCP, or endoscopic retrograde colon-pancreatic adductory, is a procedure to examine and treat problems in the bile and pancreatic ducts. A doctor uses an endoscope, a flexible tube with a camera, inserted through the mouth to the small intestine where the ducts drain. A catheter injects contrast dye into the ducts, and x-rays show blockages, stones, tumors, or narrowing. It's done for symptoms like jaundice, unexplained abdominal pain, or abnormal liver tests, often linked to gallstones, chronic pancreatitis, bile duct strictures, or liver disease complications. ERCP can also fix issues like fodder by placing stents or removing stones. It's both diagnostic and therapeutic, but carries risks like pancreatitis or bleeding. Want more on the procedure's steps or when it's needed?
That's all good. Okay, let me ask you about the fibroscan. Tell me about transient elastography.
A fibroscan is a non-invasive test using ultrasound to measure liver stiffness and fat content, helping assess fibrosis or steatosis in conditions like MASLD or cirrhosis. It doesn't involve anatomy dissection or histographically. Likely you meant histology, the study of tissue under a microscope. Instead, a probe placed on the skin over the liver sends vibrations to gauge stiffness, reported in kilopascals, kPa. Higher values indicate more scarring. It also measures fat via a CAP score, controlled attenuation parameter. It's quick, done outpatient, and tracks liver health without biopsies, though severe obesity or ascites can skew results. Want more on how it compares to biopsy or its role?
Let's go back to diarrhea. So we have causes of chronic diarrhea. They might be endocrine, they might be small bowel, colonic, pancreatic, See, tell me a few diseases from each category and justify why they are in that category.
Chronic diarrhea, lasting over 4 weeks, has multiple causes, grouped by the affected system. Here are examples. Endocrine, hyperthyroidism. Overactive thyroid speeds metabolism, increasing gut motility and causing loose stools. Carcinoid syndrome releases hormones like serotonin, triggering diarrhea. These arise from hormonal imbalances affecting gut function. Small bowel. Celiac disease damages the small kishechnik from gluten, impairing nutrient absorption and causing watery diarrhea. Crohn's disease inflames the small bowel, leading to malabsorption and loose stools. These involve small intestine dysfunction, disrupting digestion. Colonic. Ulcerative colitis causes colon inflammation, producing bloody, frequent diarrhea. Irritable bowel syndrome, IBSD, alters colon motility via gut-brain miscommunication, leading to loose stools. These stem from colon-specific inflammation or motility issues. Pancreatic. Chronic pancreatitis impairs enzyme production, reducing fat digestion and causing greasy, foul-smelling diarrhea, steatorrhea. Pancreatic cancer can block enzyme release, leading to similar malabsorption. These result from pancreatic insufficiency affecting digestion. Want details on diagnosing or treating any of these?
That's so good. And what are the mechanisms of diarrhea? We have osmotic, steatorrhea, secretory, inflammatory, neoplastic. Explain these.
Diarrhea's mechanisms explain how it happens. Osmotic. Undigested substances, like lactose and lactose intolerance, or unabsorbed carbs and celiac disease, pull water into the gut, causing watery stools. Stops with fasting. Secretory. Toxins like from cholera or E. coli, or hormones like in carcinoid syndrome, make the gut secrete water and electrolytes, leading to large volume persistent diarrhea, even when fasting. Inflammatory. Conditions like Crohn's or ulcerative colitis damage gut lining, causing mucus, blood, and fluid leakage, resulting in frequent bloody stools. Neoplastic. Tumors like colon cancer or carcinoid tumors can obstruct or secrete hormones, altering gut motility or fluid balance, leading to diarrhea. Each disrupts fluid absorption or increases gut fluid. Want more on specific diseases tied to these or how they're treated?
So what investigations do we do with? So we have stool tests, fecal elastase. Explain that. Fecal calprotectin. Yeah.
Investigating chronic diarrhea uses stool tests to pinpoint causes. Fecal elastase tests pancreatic function. Low levels, below 200 nucleons per D, indicate pancreatic insufficiency, like in chronic pancreatitis, where enzyme production fails, causing greasy diarrhea. Fecal calprotectin detects inflammation in the gut. Elevated levels above 50, 100 nucleons per D suggest inflammatory bowel diseases like Crohn's or ulcerative colitis. Other stool tests include cultures for bacterial infections, e.g. Salmonella, ova and parasite exams for Giardia or Cryptosporidium, and occult blood tests for cancer or colitis. These guide diagnosis by identifying malabsorption, inflammation, or infection. Want more on how these fit into a full diagnostic workup or what follows abnormal results?
So how does ulcerative colitis and Crohn's disease look differently regarding their endoscopic appearance?
Ulcerative colitis and Crohn's disease have distinct endoscopic appearances. Ulcerative colitis shows continuous inflammation starting at the rectum, with uniform redness, erosion, ulcers, and loss of normal vascular patterns, affecting only the colon's inner lining. Crohn's disease has patchy, skip lesion inflammation anywhere from mouth to anus, with deep, serpentine ulcers, cobblestoning, irregular mucosa, and transmural involvement, often sparing the rectum. Ulcerative colitis is superficial and colonic. Crohn's is deeper and sporadic. Want more on how these guide treatment or diagnosis?
Tell me more about their differences.
Ulcerative
So
colitis.
ulcerative colitis is only the colon. Crohn's is any part of the GI tract. But how does the name give this away?
The names ulcerative colitis and Crohn's disease hint at their differences. Ulcerative colitis points to colitis, colon inflammation, and ulcerative, causing ulcers in the colon's inner lining, signaling its focus on the colon, starting from the rectum and spreading continuously. Crohn's disease, named after Dr. Burl Crohn, doesn't specify a location in its name, reflecting its ability to affect any part of the gastrointestinal tract from mouth to anus in a patchy, skip lesion pattern, with deeper, transmural inflammation. UC's name ties it to the colon.
And ulcerative colitis is continuous mucosal inflammation.
Exactly. Ulcerative colitis features continuous mucosal inflammation, starting at the rectum and extending uniformly through the colon's inner lining, without skipping areas. This contrasts with Crohn's, which has patchy, transmural inflammation anywhere in the GI tract. UC's inflammation is superficial, causing redness, ulcers, and bleeding, limited to the colon. Want more on how this affects symptoms or treatment?
Okay. So, what's going on with granulomas? So, ulcerative colitis, continuity, and no granulomas. But Crohn's discontinues and often has granulomatous transmural inflammation. Explain this difference.
You're spot on. Ulcerative colitis, UC, has continuous mucosal inflammation limited to the colon's inner lining, with no granulomas, just ulcers, redness, and superficial damage. Crohn's disease, however, shows discontinuous, skip lesion inflammation affecting any GI tract segment, with transmural inflammation through all gut wall layers. Crohn's often forms granulomas, which are clusters of immune cells, like macrophages, forming a walled-off response to chronic inflammation, seen in about 15–30% of cases. These granulomas, visible on biopsy, are a hallmark of Crohn's, reflecting its deeper, more systemic immune reaction, unlike UC's more localized mucosal attack. Want more on how granulomas aid diagnosis or impact Crohn's treatment?
I don't understand why Crohn's has granulomas though. And
Crohn's disease forms granulomas because of its intense, chronic immune response. The immune system, triggered by factors like genetics, gut bacteria, or environmental stressors, goes into overdrive, recruiting macrophages to wall off perceived threats in the gut tissue. These macrophages clump into granulomas, clusters of immune cells, to contain inflammation, especially since Crohn's involves deeper, transmural, full-thickness gut wall damage.
okay,
This doesn't happen.
And hydrocortisone, how does that help with ulcerative colitis?
Hydrocortisone, a corticosteroid, reduces inflammation in ulcerative colitis by suppressing the immune system's overactive response. It dampens cytokine production and immune cell activity, calming the continuous mucosal inflammation in the colon, which causes ulcers, bleeding, and diarrhea. Given as enemas,
What if we have failure to respond to steroids? How would infliximab help or colectomy?
if steroids like hydrocortisone fail in ulcerative colitis, infliximab or colectomy are options. Infliximab, a biologic anti-TNF drug, targets tumor necrosis factor, a key inflammatory protein, reducing severe mucosal inflammation to control symptoms and promote healing, often used for moderate to severe UC unresponsive to steroids. Colectomy, surgical removal of the colon, is a last resort for refractory or life-threatening UC, eliminating the diseased tissue but requiring an ileostomy or pouch for waste. Infliximab aims to save the colon. Colectomy cures UC by removing it. Want more on how these are chosen or their outcomes?